My name's Gary. I'm here with my colleague Suzanne Petrie from the Australian Government Department of Health, and welcome to today's session. First of all, I'd just like to acknowledge the traditional owners and custodians of the land in which we meet today and pay my respects to elders past, present and emerging. I'd also like to extend that acknowledgement and respect to any Aboriginal or Torres Strait Islander person who is here today. So welcome to today's NPAAC seminar on the recently updated document, The Requirements for Supervision in the Clinical Governance of Medical Pathology Laboratories. This was published at the end of June this year, and it will be effective from the beginning of December this year. And this document is now a standard which is referenced in a legislative instrument known as the Health Insurance Accredited Pathology Laboratories Approval Principles 2017. So by way of background, I'd just like to remind members of the audience that NPAAC, the National Pathology Accreditation Advisory Council, is a ministerially appointed expert committee that advises the Australian Government and state and territory government health ministers on matters relating to pathology accreditation. And this includes pathology quality issues. The Department of Health supports the National Pathology Accreditation Program and therefore NPAAC. Associate Professor Beverly Rowbotham is the current chair of NPAAC, and Dr. Tony Bhadrak is the deputy chair of NPAAC as well as the chair of the NPAAC Document Review and Liaison Committee, and he chaired the NPAAC Technical Committee that reviewed the supervision requirements. The aim of today's seminar is to talk through the NPAAC requirements for supervision in the clinical governance of medical pathology laboratories, an emphasis on that subtle change from the old requirement, including now clinical governance. And please note that NPAAC is focused on patient safety and a risk-based approach to accreditation. So these requirements include a risk-based approach to governance describing professional accountability in medical pathology services, optimal supervision and clinical governance arrangements for pathology laboratories that promote safe performance of pathology services and improve patient outcomes. Professor Rowbotham will outline the risk-based approach to pathology accreditation and NPAAC strategic direction, and then Dr. Bhadrak will outline the key requirements within the supervision requirements. And if I could just ask members of the audience to bear in mind that members of council who are here today are able to provide interpretive advice about the standards documents. However, it wouldn't be appropriate for them to provide advice necessarily around the operational requirements that might be peculiar to your pathology practice. At the end of today's seminar, there'll be time for questions. Happy for people to raise questions at the end. What I'd also appreciate is that in addition to verbal questions, if you could follow that up with an email to the NPAAC Secretariat, npac@gov.health.au. The reason for that is that what we hope to do over the 3 seminars that we're doing is to consolidate the questions and answers and make them available on the NPAAC website. And if I could let everybody in the audience know that today's seminar is being recorded and that we will be looking to upload that recording to the NPAAC website as well. So now it gives me pleasure in introducing Professor Bev Rowbotham. Bev is a graduate of the University of Queensland, where she graduated with first-class honours in medicine, and after clinical and laboratory training in haematology, Bev went to the Mayo Clinic to undertake research for which she was awarded a Doctorate of Medicine. Up until recently, Bev was the Director of Haematology at Sullivan and Nicolaides and Partners Pathology, and she is a former past President of the Royal College of Pathologists of Australasia. And Bev is now the Chair of Federal Council of the Australian Medical Association. Bev is a ministerially appointed member of 4 national committees, including the MBS Task Force, and for the last 8 years, Bev's been a director of Avant Mutual Group, which is Australia's largest medical indemnity insurance provider. And from that, she has learnt a lot about risk management. Thank you very much, Bev.
As Gary has said, the NPAAC Council is very keen to have a direct conversation with you about our standards. In the past, we've let them speak for themselves, and that's had a variable outcome, a surprising amount of variability in the interpretation of standards over the years. And that's not good for the patients who the standards are essentially written for, and it's certainly not good for the labs or the accrediting body. We're very keen to help with the interpretation of the standards. As Gary said, they are legislated, so we're not here to debate the content. We're here to explain the purpose of the standards and the implementation of them. So the session will be recorded, so any of your colleagues who would like to hear what was happening today, please direct them to the website, and we've got a lot of questions and answers now ready to be uploaded. So today, my purpose today is to talk about the context around the revision of the standard. Can you see through me, or am I exactly in the wrong place? This way, all right, okay. I'll stand in the corner. What were we trying to do? Why didn't we leave that 2007 document alone? And I hope by the end of it you'll understand that we consider the changes we've made to be in the best interests of patients in terms of protecting them from possible harm while they're undergoing pathology testing. Better for the laboratory professionals. The last thing a laboratory professional wants to have is an incidence of patient harm on their watch in their laboratory. Certainly better for them when it comes to the accreditation process, as we believe the standard is much clearer than previously. And lastly, I hope you will accept our commitment to you that we will assist in any way we can to help with the interpretation of our standards. Thank you. So a bit of a recap on what NPAAC does before we launch into this one. And the entire purpose of NPAAC, established in legislation for the Australian government, is to reduce the risk of patient harm from pathology testing. That's what we do. If you go to regulate industries, it's always about the possible risk to the general public, and NPAAC is no different. We were the first of the patient safety organisations in Australia, followed 10 years later by TGA and another 10 years later by the Commission, and we work closely with those organisations. So the main piece of work NPAAC has undertaken in the last 3 years is a shift from a compliance focus to a risk-based approach to regulation of pathology services. And this has been a big shift. We haven't done it all by ourselves. All around the world, this shift is taking place, and in all sectors: healthcare, banking, policing, environmental protection. And this is for two reasons. First of all, the community expects to be protected from the risk of harm. They understand compliance, they're very happy with checklists and the fact that we are compliant with various things, but what they really want is to be protected from risk. And this has certainly got upside for the sectors, including our own, because it gives us the chance to improve on our return on the effort we expend. The compliance approach has served us very well, and it won't ever not be a part of pathology accreditation. But it had the gain had diminished as the years have gone by. This risk-based approach allows us to call out the risks, and we've done that in the RMPS document. We've specifically wanted to help labs address the risks which we see from our gathering of the evidence, and have them develop a plan around how they manage those risks in their laboratory. NATA has come on board with this approach and will accredit against this risk-based framework, and ISO is also in the process of getting together a risk-based approach to its accreditation documents. That's just underway now, and there's a lengthy delay in ISO documents, but that should appear in the next few years. Okay, so we turn now to our PEAK documents, which have both been reissued this year. Requirements for medical pathology services. It's a revision of a 2013 document, and the requirements for supervision in the clinical governance of medical pathology laboratories. And the last time this was issued was in 2007. Now, these documents need to be read together as a pair. They They are a piece of work, the two of them. The first one, the requirements for medical pathology services, describes what people are doing in a pathology service. If you go and stand in the middle of your pathology service and look around, you will see the activities described in RMPS underway. The second document, the requirements for supervision, is the view that you have as you stand at the doorway. This is an entirely different document. This is about the person who's come to the door and has said, who's responsible for the testing in this laboratory? Who can I hold accountable for the error in this test and what happened to this patient? So this is the view from the doorway as they look in. Okay, so why did we have to change any of these documents? And the answer is because the world has changed. First of all, and most obviously to all of us, pathology services have changed. We've all been in pathology, we've lived through these changes. Firstly, the volume of testing in MBS testing, and I'm sure equally so in the public sector, has doubled in the last 11 years. There's an enormous amount of testing going on in Australian laboratories. We've moved where the testing is done. A lot of work now is centralised from smaller labs, particularly in the regions, into big labs. And we've changed and we've wrapped this testing around in networks rather than standalone labs. And we've got new technologies. Point of care is reaching maturity, and we have the new technologies, most obviously in genomics. The second thing that has changed is that pathology, which has always been regarded as an important patient service, is now getting a following, a building of understanding that it's an essential service. And we know this because every now and then it stops working. And we have examples of this in Leeds in 2016. The pathology IT system crashed for 5 weeks. And during that time, general practice testing, which is done through that hospital, ceased, and all emergency surgery ceased. And day after day, the local newspaper followed the fact that this service, this essential service for healthcare, had fallen over. And in Australia, with our many natural disasters, one of the things which is we have to check on very regularly is, apart from all other aspects of healthcare being available during cyclones and road blockages, etc., and power outages, is pathology able to function? The next thing that's changed is this understanding of the centrality of pathology to healthcare innovation. And we see this now with the rise of personalised medicine, the screening programs, which are now not only cervical screening, now also bowel screening, and on it goes, antimicrobial susceptibility testing, etc. And this came home to me very clearly last week when I visited the department in Canberra and met with the various department heads who run these various policy areas. And it's very clear that pathology is central to their work. Lastly, there's a change in what our referrers expect of us. Where we once provided tests, we now are required, and many of us always thought we provided, an end-to-end clinical service that includes a test. And this is most clearly demonstrated in the call for stewardship around pathology requesting, and for the requirement that pathologists, as well as everybody else in medical care, be a part of open disclosure processes when events go wrong. Okay, so not only has pathology changed, but so have consumer expectations. We know that. We are consumers. We expect more than we did 10 years ago. Consumers are very literate now about pathology. If you tell anybody what you do for a living, you're immediately a part of a discussion about PSA and haemoglobin A1Cs and cervical screening, etc. And in terms of, they understand the value of pathology. The number one wish for the My Health Record content from the Consumers Health Forum is that the pathology results be in it. They also understand that things go wrong in pathology. There can be harmful events. They know that because of the media, and we see a lot of media these days. So they know about Leeds, particularly in the UK. They know about Theranos all over America, where millions of tests had to be struck out because in fact the technology was not fit for purpose and the results were wrong. And they know about errors in Australia as well, because every now and then we will have a misadventure, as happened to South Australian Pathology in 2016 with their PSA testing. And I will refer to that case because it is an Australian case and it has lessons for all of us. Lastly, they have an expectation of best practice and governance. They expect us to do a good job. So I want to just take a moment on this, because this is a very significant part of NPAAC's charter, the public confidence in pathology testing. And they expect us of all aspects of healthcare. They expect of the banking and insurance industry and the aged care, etc. But if we stay with healthcare, I do want to refer now to the SA pathology incident, because there were 2 very good reviews came out of that episode. And these reviews can still be accessed via the SA pathology website. And in this instance, the assay was set up incorrectly, so that there were results generated which led some patients to be advised that they had recurrence of their cancers, and some of them went on to have further therapy, including radiotherapy. And all of this happened in a time frame before the errors with the assay were recognised and could be corrected. So I've included some excerpts from these reviews. The first one, on the 3rd of March, a patient contacted the Executive Director with an email titled "Being on Death Row for 30 Days." And this, explaining his anxiety about his test, where he thought the cancer had come back. And I think this is a very good example of how let down this patient felt by a pathology laboratory which got his result wrong. The second thing is the actual report from the commission who did the review of this, and they again wanted to address the public confidence in testing and recommended a formal apology and implementation of the lessons which had been learned from the episode. So this is a very good summary of the public's interest in what happens to them at the hands of a pathology service. And what the key thing in modern healthcare, in policy, throughout the world now, is accountability. And the call for it just continues to increase. So if we go again to Australian circumstances, this is certainly the recommendations that came out of the Dr. Patel case in Bundaberg, where senior health officials from the Queensland Government were subjected to legal proceedings over their accountability for what happened in that circumstance, and again the reviews of the South Australia pathology episode. And again, I've got some quotes here from those reviews, and they describe a top-down management process in SA pathology, although identified on paper and allocated to pathologists and scientists, carried no accountability or responsibility. It's a recurrent theme throughout these reports. And I also want to highlight equally, they do not have in place an appropriate escalating communication response procedure to deal with significant abnormal results. So complaint handling, open disclosure, and so it goes. So South Australia Pathology is not alone on this. NATA have, in recent years, undertaken some governance reviews of laboratories around Australia and report unclear governance in a number of Australian laboratories, many of which run, as we all used to run, on goodwill and good understanding of people who've worked together for a long time, that you'll do this and I'll do that, and an intuitive process, not well documented. And that is vulnerable, as we know with our own assays for PSA or any process which is not documented is a vulnerable process, because things change and people forget what what was in place, or more particularly, important people leave the workplace and take away with them an understanding of how the system worked. So the other piece of information that we have now is QAP put out a survey of the handling of critical results in laboratories, and similarly found a very widespread failure of standardisation of how Australian laboratories manage their critical results. Everybody had their own, and they were highly variable. Okay, so the purpose of revising the standard to be fit for purpose this year and for the next few years is to strengthen accountability, embed the responsibility for risk management in the daily operations of the laboratory, sort out our laboratory categories so that they match current models of practice. We're very committed to a skilled workforce, and lastly, we're committed to clarity around the standards, as one of the major criticisms of the 2007 document was that it wasn't clear. So the principles of this standard are, number one, that a medical practitioner is the designated person who is accountable for the provision of a medical pathology service, that there be a clear delegation process, and that supervision is delegated to staff who have the appropriate training, qualifications, scope of practice and CPD for that specific set of tests. So I want to now just touch on several issues which have been raised in feedback over the last couple of months to see if I can clarify it. And I'm disappointed that that's not bigger. I put too much on that slide. So the first thing I want to go to is the issue of the role of clinical scientists in this case, NG laboratories. And this has been a source of some distress to clinical scientists, and certainly some distress to those of us in NPAAC who have supported, from the day naught, the role of clinical scientists in pathology laboratories. The new standard builds on the old standard in all cases. In the past, we talked about expert in group of tests. This time we talk about scope of practice. In the old standard, there was a clause that said GXGY laboratories operate under the direction, control, full-time supervision of a supervising pathologist or senior scientist who's expert in the group of tests. A second clause, which is regrettably is not often quoted back, is that where a GX or GY laboratory is supervised by a senior scientist, there must also be a pathologist present during the normal working hours of the laboratory. So this establishes the principle of the partnership. In 2018, we have asked that the designated person delegates to other pathologists with relevant scope of practice, and these pathologists may further delegate supervision to clinical scientists with relevant scope of practice. It makes no sense for a clinical scientist with a specific scope of practice to be partnered up with a generic pathologist. In this day and age, the general public would wonder what was going on if an anatomical pathologist was the partner pathologist for a clinical scientist in genetics or immunology. So, as I said, we remain highly committed to the role that pathologists and clinical scientists play in the delivery of pathology services. This interpretation of that role is not of our own making. It does reflect the Australian regulatory framework. So medical practitioners are trained and qualified to provide the medical services, and accountability to the referrers and the community rests with that medical practitioner. Medical practitioners are registered and they have mandatory professional indemnity insurance. Furthermore, they sign an APP undertaking, and if anybody has not read the APP undertaking, it is a very sobering document and a very significant personal commitment to take responsibility for pathology services. And lastly, the Australian Commission for Safety and Quality in Healthcare very clearly believes the medical practitioner is responsible for the pathology service, and in particular for the errors which might arise from testing. And this long paragraph describes the Clause 80 in their report, The responsibility to maintain quality in Australia lies with the supervising pathologist as the approved pathology provider, under a formal agreement with the Health Insurance Commission stating they take personal responsibility for rendering the services. It's vital that pathologists, as the only medically qualified staff, fulfil their bridging role for clinicians by ensuring the pathology services fulfil their clinical objective. This is done by remaining in close contact with both the laboratory and then the clinician it serves, and in discharging these vital obligations, a pathologist must be supported by the administrative structure of the laboratory, ideally with each supervising pathologist represented at all senior administration meetings, etc. The next issue that I'd like to provide some context on is S laboratories. Now, of all the categories, the S laboratory has flourished in the last 11 years. There are hundreds of laboratories in Australia who are classified as S laboratories. And this is a very heterogeneous group of laboratories. And it has been a very difficult task to try and manage a review which dealt with patient risk against a very broad range of services. Our aim is to restore S laboratories to what they once were, and this was specialised testing. Usually narrow testing, a non-pathologist medical practitioner as the designated person who has specific expertise in this area of testing, and a small group of patients. Once testing is mainstream, once it is commonplace, once it is required for large numbers of the Australian public, it is in G laboratories, and there's no need for it to be replicated in S laboratories. The other big user of the S laboratory category are the point of care laboratories, and we want to see them moved. We want them either as part of the pathology practices that many of them belong to, or as we'll see in the M lab, where they belong to an individual medical practitioner. In the effort to, I'll just finish off. So we recognise there will be implementation issues around the standard as it's currently written for S labs, and in response to that we have accepted a revision, and we will remove clause C4.31, in-house IVDs must not be used, and we will include the RTAC qualification as one of the lists of qualifications as a clinical scientist, and that's to meet the feedback that we have received on those issues. Lastly, the M labs. There are not very many M labs, this is where point of care testing should be housed if it is being done under the supervision of medical practitioners for their own group of patients. Okay, so I hope that gives you a background to it before I hand over to Tony. The purpose of the standard is to reduce the risk to patients of harm from pathology testing by responding to community expectations of best practice and governance. We've written the standards to help pathology services to identify risks, to strengthen accountability and reporting lines, and reinforce the crucial role of laboratory professionals. And lastly, we are committed to helping you understand these standards. Thank you.
Thank you very much, Bev. Now, I'd like to introduce Dr. Tony Bhadrak. Tony is the current Deputy Chair of NPAAC and the CEO of the Royal College of Pathologists of Australasia Quality Assurance Program Proprietary Limited. Tony is also the Chief Examiner of the Faculty of Science for the College, and he's worked in public and private pathology laboratories as a clinical biochemist. Tony holds a PhD and fellowship of many learned societies, including AACB, AIMS, as well as the Faculty of Science for the College. Tony.
Thank you, Gary, and thank you, Bev. So just while the presentation is coming up, I'm really going to go through the standard in some detail, a series of clauses where I hope I'll be able to elucidate some of the issues that Bev's raised. I might just say that I've been working on this standard. I've been a part of this drafting committee for, I think it's 11 years now. And during that time, there's actually been 4 chairs of the committee. I think almost as many of there have been prime ministers in the same time. And this really reflects the difficulty of this standard. As Bev's hinted at or said, really, in that time there's been a lot of changes in the environment, a lot of changes in expectation. The previous standard was the 2007 edition, but in fact, really, the 2003, it's a slight redress of the 2003 document. So this is really, this document, the 2007 document, the current document, relates to turn of the century pathology. That's not the way we practice anymore. That's not the way that the community expectations have evolved. But the fact that it's taken us so long, and there have also been, during that 11 years, there's been 4 public consultations, I think it illustrates just how difficult this standard has been to change.
I'm going to have to drive.
Oh, sorry, okay, yep. So I'll just, oh, you sure? I think I'm right. Yeah, I'm right. So, yep. So I'll start. So just there's lots of changes in the document, and some of them are not subtle. But some of them are subtle. So the first thing is the 2007 document was called entitled Requirements for the Supervision of Pathology Laboratories. The 2018 document is called Requirements for the Supervision in the Clinical Governance of Pathology Laboratories. So it's about clinical governance. It's not about some organisational structure. It's not about a title within an organisation. It's about clinical governance and accountability for clinical governance. So that's the first thing we need to stress. The sort of one of the tenets behind the drafting committee's redraft of the document was that we see that a pathology request is a medical consultation. A medical consultation between a referring doctor, clinician, laboratory, but specifically to a pathologist in the case of a G-lab or a specialist or a GP. So it's a medical consultation between one medical officer and another medical officer. So what I'm going to talk about is really, I'll go through the 2018 standard in comparison with the 2007 standard to hopefully make clear what the differences are. You'll see that really what we've done, as Bev has hinted at, is we've done a lot of clarification. There have been some clauses in the 2007 document which really weren't clear. We've tried to clarify those, bearing in mind the statement that I just made about we see a pathology request as a medical consultation. I'll explain some new clauses as well, and then I'll talk about some of the implementation issues. And the implementation issues really relate, as Bev suggested, in us trying to write a document, in the case of S-labs in particular, that covers a whole gamut of laboratories, from very, very, very specialised laboratories to point-of-care laboratories. To try and write standards that determine accountability in those labs was almost impossible. So as a consequence, we've had to provide some changes or produce some changes. So just going back to the 2007 document, really it had a narrow operational view to the modern concept that we've now changed, and that again, the pathology request is basically a contract between the patient, the referring medical practitioner and the laboratory team. It's a medical consultation. The 2018 document is risk-based, and it's risk-based because one of the reasons why it took us so long to come up with the standard was we would have requests about can you put in the document some way of including complexity and volume into the standard. So a question we will get after public consultation, somebody would say from the community, you've mandated that in fact you need a certain number of pathologists for this amount of work, but we in fact know that there are much larger laboratories, much smaller laboratories, some laboratories dealing with more complexity. Can you in fact write a standard that says for this volume of testing that's this complex you need this many people to supervise it? We just can't do that, and nobody could. But that's how compliance has driven our standards, that people want simple answers like that. We can't give simple answers like that. A complex test today will be a simple test tomorrow. So that's why we've gone down, that's one of the reasons why we've gone down the risk-based approach. Somebody in that laboratory, the accountable person in that laboratory, has to make those decisions. They have to make those decisions on a sort of month-by-month, year-by-year basis. what's at risk to that laboratory is really what the accountable person is there about. Other things that we've done, we've clarified the word supervisor. When you go through the 2007 document, there's lots of supervisors. We've used that word a number of times that really relate to completely different people. So that was confusing. We've clarified what supervision means, what delegation means. We've recognised point of care. Since turn of the century, there's a lot more point of care out there. And in fact, we've now recognised that formally in the document, particularly with public networks. So this is from the 2007 document. Supervising pathologist means a pathologist who has had training to allow him or her to supervise a medical testing laboratory. Pretty vague. And we say later that under the direction, control and full-time supervision of a supervising pathologist or senior scientist who is expert in the group or groups concerned. What we've come now in the 2018 document is we've defined what clinical governance is. So remember the document's entitled Supervision and Clinical Governance. So it's a specific type of supervision. It's about clinical governance, which is about accountability. So we've defined what that means. We've defined competence because there's an inference that people are competent. We haven't actually defined what that means. We've defined delegation and designated person, on-site manager, on-site operator, and what's a scope of practice. Before, some of those terms, on-site manager or on-site supervisor, and there were other supervisors in there, so we've clarified what supervision means and who is the supervisor. A strong focus on accountability, because as Bev said, that's what this document is all about. It's about accountability to the public for the medical pathology service. And we've also continued with this concept of full-time pathologist hours, what that actually means. So I'll go through the document now. So under the scope section, it describes the role and responsibilities of the designated person. So the designated person is the person who's ultimately accountable for that pathology service. There's one designated person in each pathology service, be it a G lab or an M lab or an S lab. There is one accountable person. That's the designated person. They're ultimately responsible for everything in that service. They can delegate, but they're ultimately responsible. There's still, in terms of categories of laboratories, there's still sort of 5. If you look really closely, I think there might be 6. But in fact, there's basically still 5. So there's a G lab, which is a general pathology laboratory. There's an M lab, which really covers GP practice, and there's an S lab, which covers practices where there's a specialist, a non-pathologist, in charge. And we've clarified, again, we're trying to redefine what an S lab is, and that's why we've added not a pathologist. Pathologist testing should be conducted in a G lab, not an S lab. It's a different sort of practice where the requirements for the designated person are quite different, because we see S labs as being different to G labs. One is doing specialised testing, one is doing routine testing. What we've added is there were GXs and GY labs in the previous document. We've changed the definition of a GY in this lab. In the old document, GX and GY were basically the same, but the number of pathologists in the organisation differed, whether there were more than 2 or 2 or less. We've now seen, and this reflects what goes on in the real world of pathology, that there are different sorts of labs with pathologists in them. There are sort of the headquarter lab, a GX lab, we're still going to call that, where for every discipline where testing is performed, there's a pathologist who's accountable for that testing, be it hematology or chemistry or whatever. But in most networks, there are also labs where in fact they are part of the same network, but there are pathologists there, but there aren't pathologists there to cover every discipline. So there might be a hematologist or an AP, but they're part of that same network. To recognise that, we've now defined a GY category, where it's just like a GX laboratory and it's part of the same network that the GX is the head of, but in fact not all disciplines are represented in that laboratory by a pathologist. So they can be delegated responsibility for that testing which is performed there. But if there's not a pathologist in that lab and there's other testing being performed, the designated person in charge of the whole network can delegate to a pathologist in the GX laboratory to look after what's going on in the GY laboratory where there's no other pathologist. So that's just a recognition of what's actually going on in practice. We've included in the category B labs a point of care lab for public networks, because again, as Bev said, there's hundreds of S labs, and a number of those S labs are point of care labs. And you can't tell me that a specialist lab that's doing point of care glucoses can be considered to be doing complex analysis. We've also included an SB lab. This is one where we sort of snuck it in. So we recognise that in some ART labs there in fact is a hub and spoke model where there's a sort of a main lab, but there are smaller labs that are in the same APP, operated by the same owner, where in fact there's some testing being performed in those smaller labs. We recognise that in fact they're networks. And again, just reiterating what Bev has said, the current legislative framework mandates that for a pathology service to be rebated under Medicare, it must be supervised by a pathologist or medical specialist. And we've said all tests are supervised by competent persons, and we've defined what that means, who are working within the scope of practice, and we'll talk about that in a minute, and that they will be able to demonstrate effective clinical governance. It's about accountability. And that's just for your interest. When these slides come out, that's the approved pathology practitioner undertaking. And if you read this document, you will see there's a lot of similarity between what this requests people to do, pathologists to do, and what the supervision document in fact expects. And for one of our forays into the standard, we actually tried to link those even more closely together, but that really wasn't successful. So, onto the definitions page. We've defined what the designated person is, and I say within a pathology network, within a GX laboratory. And by the way, a GX laboratory may in fact just do anatomical pathology. So it doesn't have to have the whole gamut of testing. It might just do chemistry, it might just do haematology, it might just do AP. But there's one person, the designated person, who's ultimately accountable for that GX laboratory and any other laboratories that are part of that network. So, medical practitioner, appropriate qualifications, competence and a relevant scope of practice. This pathologist or specialist will have a scope of practice. So they may be an AP or a chemist or whatever. They have a scope of practice. So they can in fact supervise testing within that scope of practice. If that laboratory is doing other testing, they need to delegate to another pathologist with an appropriate scope of practice who will be accountable for that testing. Pathology network, we've defined what that means. Some of our definitions are quite light and general. That's been deliberate. That's been deliberate because we're trying to move away from being completely prescriptive about everything, because it's difficult. We've defined what a scope of practice means. And this is getting away from an expert in a group of tests, because we need some sort of oversight as to what that actually means. And it requires assessment or competence by a relevant college, professional society or credentialing body. We've also defined a laboratory, a much smaller definition than the previous definition, and that again reflects what's happening out there and gives some more scope. We've in conjunction with the RMPS document, we've defined what a medical pathology service is, what a pathology network is, quality manager. We've actually included quality manager in this document now, so there's a recognition that the quality manager has an important role. This is really based on the ISO 15189 document as well, and reflected in the RMPS document. So the quality manager is recognised, and they're recognised that they have a key role to play in the supervision of branch and GY laboratories. We define open disclosure. And again, going through the definitions, clinical scientist, we changed the title of this role. In the previous document, it was called a clinical scientist. Sorry if I'm in the way. As a senior scientist, and even as late as last week, We got emails from people in our profession saying, I'm a senior scientist. I've worked in a lab for 30 years. How can I not be a senior scientist? People do not understand that since at least 2003, to be a senior scientist in terms of NPAAC, you have to have qualifications. Have to be qualifications as determined or described in the NPAAC document. It's not just a matter of hanging around for a long time. That's still not clear. But in fact, we've extended the definition slightly. We've included the words by examination. So not only do you have to have a fellowship from one of these recognised groups, it has to be by examination. It can't be an honorary fellow. We've added Fellow of the ASC and the Fellow of the Faculty of Science because those fellowships have arisen since 2007. We've modified slightly the PhD because this has been quite topical, so we've tried to tighten it up even further by just saying in a subject relevant to a scope of diagnostic testing. In the introduction, we say the requirements intend to require the requirements intent to require a clearly documented and understood governance structure that ensures all testing is supervised by persons who are appropriately qualified, competent and operating within the scope of practice. So we hope this is about clarity. It's clear it's about governance structure, not organisational structure. Designated person must make risk-based decisions. They're the only person who's now accountable who can make a lot of these decisions about staffing, training, etc. Number of tests performed, qualifications, experience of scientific staff, level of pathologist supervision. We can't write standards that will cover this. Somebody has to be accountable. This is from 2007, and again, it was only when I was preparing this talk last week that I sort of realised that in fact the section on supervision was headed staffing with a big S and supervision with a little s. So that just shows you how things have changed in the last 12 years. From this document, there shall be sufficient professional and support staff with adequate training and experience to supervise and conduct the work of the laboratory. I'll show it to you later. We now actually have a definition of what is expected in a supervisory visit. In the Appendix A of the document, you'll see there's some dot points as to what we consider to be supervision, rather than just expecting somehow people think or understand what supervision means. Again, in this document, in a category GX or GY, the supervising pathologist or senior scientist must be present during normal working hours. Just so you know, we tried initially not to put in a definition of normal working hours. We will now add back a definition of normal working hours because there was seen to be an issue with the interpretation of what normal working hours means. Where a GX or GY laboratory is supervised by a senior scientist, there must also be a pathologist present during normal working hours of the laboratory. And again, I must admit, it's only when you go back and look at this clause with the benefit of hindsight, you think, that's crazy. What does this mean? There's a sort of a token pathologist that's wheeled out and just sits in the back of the room waiting. It really is, it's ludicrous. This is the standard that we have lived by up till now. We needed clarity about what's this pathologist, what's their role, why do they have to be there? And that's what we've done. But it also reinforces that, in fact, as Bev said, there's always been a partnership between the pathologist and the senior scientist, and there's always been a need for both people to be there because they have complementary skills and different accountability. Supervision, this is the 2018 document. Every laboratory must be under the direction and control of a designated person. And I keep going back to this. There's one designated person who's ultimately accountable for that service. Medical practitioner, because of the medico-legal requirements, responsible and accountable for the clinical governance of the medical pathology services in the laboratory. There has to be a documented clinical incident management program. That's just an expectation of all health services. All pathologists and clinical scientists who are appointed as delegates must meet CPD requirements applicable to their scope of practice. So we've mandated there must be CPD in there. That's already in 15189, but we've now mandated in this document as well. We see that that's critical. Again, just risk. We've described what a risk assessment means and what risk management means. Within the RMPS, there in fact are some further support for how you can do this work. There are lists of potential risks. So the two documents again need to be read hand in glove, and most laboratories would in fact have a risk assessment process in place. And just to reinforce this, in the new document S1.3, designated person is responsible for the establishment, implementation and operation of the risk management plan for the MPS under their direction and control. And we've described that the risk management plan must document major patient safety risks, and I say there's assistance in determining these in the RMPS. The strategies are proposed to mitigate those risks and the implementation status. So it's not just a list, you have to show that you're doing something with that list. Operation of this plan must be monitored and supported by compliance and reporting processes so that any material breach is notified to the designated person, and the plan must be reviewed regularly. So really, this is what laboratories should now be focused on. In terms of the categories of medical laboratories, they're essentially unchanged, except, as I said before, there's really just a recognition of the hub and spoke model with point of care, with S-labs, and this new category of GY labs, which is just like a GX, but there's not a pathologist on site who can supervise every group of tests, every group of tests. But that supervision is coming from the GX lab, to which the GY is a component. GX responsibility full-time on-site supervision of pathology testing may be delegated to other pathologists with a relevant scope of practice. These pathologists may further delegate to specific testing to clinical scientists. So a GY is really a GX minus, but in the same network as an overarching GX, with one designated person responsible. The branch lab, much the same, except we've now included this point of care, which reflects current practice, but we've also included, we've changed within the B labs the supervision requirements in terms of visits, where we hope it's a bit more doable, and we've increased the range of people who can do that sort of those visits. The S lab, medical pathology services comprising a laboratory performing a limited range of pathology tests for a target patient population under the supervision of a medical practitioner with specialist qualifications and competence in those tests, who is not a pathologist. So we're trying to make S labs what we think S labs should be, and that is that they're special, because they're doing complex testing to a target group of patients. GY, medical pathology service comprising a laboratory or a number of co-located laboratories performing services in a group of pathology tests under the full-time supervision and clinical governance of a designated person from the GX laboratory, and where supervision for these groups, some groups of testing in this GY laboratory, is provided by on-site, full-time, in aggregate, pathologists with a relevant scope of practice. The GY laboratory must be related to the GX laboratory, so this is part of a network. Category B, and I'm just going through the document, so as these definitions arise, I'm just going through the document. Again, it must be related to an accredited GX or GY. A branch integrated except in its location with the GX or GY. Some people have asked, is it possible to have a G laboratory and a B laboratory in the same location? You don't need to. If you've got a G laboratory where you don't have a pathologist who can supervise every area, that's a GY laboratory. That's why you don't need them anymore. Operating under the direction and control of the designated person or the delegate. Designated person may delegate, providing that the person they delegate to has got a scope of practice. It's relevant, and this includes point of care. S, this is the 2007 definition, so this is just to compare and contrast. This category is used for either a laboratory in which a limited range of tests is performed on a particular patient population. And you can see potentially why, in fact, so many labs have fallen under this definition, because that just about covers every sort of test done in Australia, really. If you just choose the patients from Queensland. Or a laboratory in which a limited range of tests is performed that are of a specialised nature and are performed under the supervision of a person having special qualifications or skills in that field. That's really what the S was always meant to cover. Where the supervisor is a medical practitioner, approved pathology services may be provided for the patients or others. So what we've done in 2018 to try and tighten up this category, medical pathology services now comprising a laboratory performing a limited range of pathology tests for a target population under the supervision of a medical practitioner with specialist qualifications and competency who is not a pathologist. That's the first thing. Tests performed must be restricted to the field of testing directly related to the qualifications and competencies and the current scope of practice. And if a laboratory proposes to undertake a wider scope of pathology testing, then they must seek accreditation as a GX or GY. This is currently what's in the document in terms of, for ART laboratories, just exactly the limited range of testing that they can undertake. And we've added, as I said, this scope and this hub and spoke model just so, in fact, we recognise what actually happens in a lot of ART laboratories. Category M really hasn't changed. It's the same as it was before. The only thing that we've done is that we've extended the requirements of the role and responsibilities of the designated person across all those labs. So they have the same requirements now as a GLab. Again, just going back now to the next part of the document, which is about supervision. The GX laboratories must operate under the direction and control of a designated person who must be a pathologist. They can only be the designated person for one GX laboratory. They can only supervise testing within their scope of practice. If they offer a wider range of testing, they must have somebody, the designated person must delegate to another pathologist with a relevant scope of practice. And there's some examples which are hard to see, but the key concept is that there's a person at the top of the pyramid. The designated person is ultimately responsible. Within that lab, they may have delegated to other pathologists who have an appropriate scope of practice and accountable for that range of testing, or they may have delegated to other B labs. There must be at least, in this GX-GY, one full-time equivalent in aggregate on-site pathologist with the relevant scope of practice for each pathology test. And just say in aggregate. For category GY, supervision must be provided by the on-site pathologists who have relevant scope of practice. Apologise for the little thingos, but this is just to demonstrate the relationship between GYs and the parent GX. And it's about clinical accountability, so it's really the designated person who's responsible and accountable for these labs. And the Bs can either be reporting directly or indirectly. Again, category B hasn't really changed. So just again to reiterate, in Appendix A, we've actually now described what supervision actually means. We've covered off on what bona fide absences, how that's going to be covered for up to 8 weeks, what the supervision visits are and who can do them, recognise the role of the quality manager. But we've also recognised that if you're the on-site manager of a B lab, you need to visit the main lab. So we've recognised that and in fact made that a clause. Supervision of Category S laboratories. Category S laboratories are different. They're research laboratories, or they're laboratories that are providing specialised complex testing. The medical practitioner, the designated person, may in fact be treating patients, so they're not going to be in the laboratory all the time. So that places more onus on the clinical scientist. So we've said that the clinical scientist with the relevant scope of practice must be on site during normal working hours. And we've defined and we've added back into the next version what normal working hours means. 4.3, as Bev has said, We realised that this was difficult to implement, so in fact that red sentence clause will be taken out. Again, just reiterating, this is the range of testing that's currently mandated in this document. SB lab is a branch, except in its location, and again, just reiterating that we recognise that practice. Supervision basically not changed. And they're just a little diagrams of the way that we see the SBs relating back to the S, and the designated person resides in the S and in the M lab. Again, it's in the document, but we've described exactly what the required supervisory activities and conditions are, at least yearly performance review, so we've defined what we think good practice is and what the operational requirements are of supervision as well. So the sort of changes, the post-implementation changes that will be in place before 1st of December. This clause will be removed. Again, and the reason that came about was trying to write a document that covered all the types of S labs. We tried to reduce the risk in certain labs, but in fact we made it a significant issue for other S labs. We're going to change the clinical scientist definition so that it includes, for ART labs, the clinical scientist must meet the criteria in the RTA Code of Practice. There are some other minor changes that will occur in the document. There's been some errors picked up about clause numbers and references to clause numbers, duplication in the appendix, so that they'll be changed as well. We're going to add this about normal working hours. So we've defined normal working hours means the hours during which the laboratory is operating and during which supervision needs to be provided on site. Again, this is to give a bit of flexibility, but also this is about risk. You know, the designated person needs to make those sort of decisions. But it should be noted that access to pathologists for consultations may need to be provided outside of normal working hours.
I asked us a question. If you look at normal hours, you can define that as 2 o'clock in the morning if you're doing chemistry.
That's why it's a risk-based approach, and somebody has to make that decision. And in terms of proposed changes, additional categories, there may be an additional number of tests added. Okay, thank you.